and for the kind introduction. I'm very pleased to talk about a topic which is very near and dear to my heart, that of the respiratory complications in children with Down syndrome, as I have been working with this vulnerable patient population since my days of fellowship at CHOP. So without further ado, I have no conflicts of interest to declare, and I will not be discussing any unapproved therapies. The objectives of the talk will be to highlight the unique anatomical and functional features of children with Down syndrome, which predispose them to respiratory complications, and also to understand the different respiratory disease patterns seen in children with Down syndrome. So in general, we know that Down syndrome caused by trisomy 21 is the most common genetic cause of intellectual disability. Its incidence ranges between 1 to 600 to 1 to 800 live births. And the main focus in the neonatal period is the cardiac management of these individuals. But we know that in children with minor or repaired congenital cardiac defects, their life expectancy goes up to 60 years of age. We also need to know that there is a multi-system nature of the disorder, and this is very important with regards to the interplay between the respiratory tract and other systems, such as the GI system and the cardiovascular system, the immune system, in manifestations of respiratory complications in these individuals. Overall, the recommendation from the American Academy of Pediatrics is that there should be routine screening and anticipatory guidance in these individuals at every child visit. With regards to the respiratory complications, data suggests that these are the most common reason for admission into the hospital for children with Down syndrome, not only in the regular pediatric wards, but also in the ICU. And they are the leading cause for excess mortality. So it's very important to be able to recognize the vulnerability of these individuals with regards to respiratory complications, make a timely diagnosis, prevent secondary complications, as we will see next, in order to optimize their health outcomes. With regards to the respiratory complications in children with Down syndrome, so without further ado, we have the most common ones and the less common ones, but another way of looking into this, if you group it into categories, depending on the system involved. And so we have either involvement of the airway, upper airway and lower airway anomalies, or we have sleep disordered breathing, otherwise known as obstructive sleep apnea, which is the most common respiratory complication in children with Down syndrome. We have pulmonary and vascular complications, of which pulmonary arterial hypertension is very important to know and acknowledge, as it happens irrespectively of the presence and severity of any underlying congenital heart defect. And also, one should be aware of other complications with regards to the pulmonary and vascular system, such as the post-op pulmonary edema or high altitude pulmonary edema, as well as pulmonary hemorrhage. These children are predisposed to frequent lower respiratory tract infections. They're predisposed to diffuse interstitial lung disease, and very commonly also they're having difficulties with regards to their immune system, and they can even have asthma. And overall, there is a whole group of complications that come from different systems and interplay with each other. So starting with the upper airway and this specific anatomy linked to children with Down syndrome, we know that they have midfacial hypoplasia and hypoplasia of the lower facial skeleton. They have narrower nasopharyngeal airways all the way to choanal atresia. They have retrognathia and macrognathia. And so there is a smaller and posteriorly displaced jaw, and that gives them relative microglossia. And as with typically developing children, the size of tonsils and adenoids does play a role in these children, particularly between the ages of 2 to 8 years of age, when the relative size of tonsils and adenoids is larger to the rest of their upper airways. But Actual studies have shown that in individuals with Down syndrome, adenotonsillar hypertrophy is by any means not the only reason leading to upper airway anatomy. So, for instance, there were 71 out of 518 children with Down syndrome, so 15% observed over a 5-year period. And of them, upper airway obstruction was noticed in about 42%. And of those, half of the children with adenotonsillar hypertrophy had more than one other findings on physical exam, which predisposed them to upper airway obstruction. With regards to their airway anomalies, we can see that these are multifactorial. There is narrowing of the airway through and through. So these patients may have subglottic stenosis, which is either congenital or acquired. And I'd like to emphasize the acquired subglottic stenosis because in these children, we need to be careful when they're undergoing elective or emergency intubation because they are going to need a smaller size ET tube. And actually a study comparing 42 individuals with Down syndrome with 32 control subjects with no history of stridor or earlier intubation, the ET tube size evaluated was 2 to 3 times smaller than that of their age-matched controls. So keep that in mind. We know that they have a smaller tracheal diameter, and some of these individuals are predisposed to have tracheal stenosis, either due to vascular rings or hypoplasia of the aortic arch. And there is also a percentage of these individuals who have complete tracheal rings, and this may have a variable manifestation clinically, either from respiratory failure requiring ICU level care or intermittent respiratory symptoms during URTIs. But all in all, the treatment for that would be laryngotracheal reconstruction or slide tracheoplasty. And so the bottom line here is that in individuals with Down syndrome and airway anomalies, which are multifactorial in nature and may need a surgical intervention, we need to be referring these patients to dedicated centers who have expertise in performing complex airway surgeries, as there's a higher risk of failure. The most common lower airway abnormality is as seen in bronchoscopies, rigid and flexible bronchoscopies is tracheobronchomalacia, and this is the dynamic intrathoracic airway collapse. So this is something that presents in individuals with noisy breathing, chronic cough, predisposition to lower respiratory tract infections, and so forth. So the most common, however, respiratory complications in children with Down syndrome is obstructive sleep apnea. Its prevalence ranges between 30 to 75% compared to 2 to 4% in typically developing children. And it actually can reach 100% if we go to adult population. And the reason for this can be twofold. There is one, and as we discussed earlier, the specifics of the airway anatomy, but also it has to do with the upper airway tone. And so in these children, there is on one end crowded upper airway with midfacial and maxillary hypoplasia. There is posterior displacement of their tongue. There can be lymphoid hyperplasia and tonsils and adenoids. There can be, on the other end, pharyngeal hypotonia. We need to remember that untreated hypothyroidism can manifest itself as obstructive sleep apnea. And so we need to screen for that. And also, of course, obesity, which plays a role in developing obstructive sleep apnea in typically developing children, for sure remains one of the risk factors in these individuals, particularly as they age. And this is due to the fact there is fat deposition across the upper airway, including the tongue, as seen in MRIs of the airways for research purposes. Now, having said that, about 97% of individuals with Down syndrome who snore end up having obstructive sleep apnea. However, there is a great mismatch between the perceived symptoms between caregivers and even physicians treating patients with Down syndrome and what actually holds true when we send these patients for a full overnight polysomnogram, which is the gold standard for diagnosing obstructive sleep apnea. So studies have shown that only about half of caregivers, and about 2/3 of physicians were right in diagnosing obstructive sleep apnea in individuals with Down syndrome based on history and physical exam alone, compared to the full overnight polysomnogram, which is the gold standard for the diagnosis and the severity of obstructive sleep apnea. And this is why the American Academy of Pediatrics has actually come up with recommendations and guidelines for all physicians that no later than the age of 4 years, all children with Down syndrome should be evaluated in a dedicated sleep center by a sleep physician and undergo a full overnight polysomnogram. Now, having said that, obstructive sleep apnea as a first line of treatment would be adenotonsillectomy, as in with pediatric patients. It's different in adults. Removing tonsils and adenoids, even if they're small in size, is going to increase the cross-sectional diameter of the upper airway, and it's going to help decrease significantly the airway resistance. However, there is a significant portion, about 2/3 of the patients with Down syndrome, who are going to have residual obstructive sleep apnea post-adenotonsillectomy, requiring other interventions, such as the use of long-term positive airway pressure therapy. We know if obstructive sleep apnea is left untreated, then it leads to a whole slew of negative neurocognitive and cardiovascular outcomes, including systemic hypertension, left ventricular hypertrophy, and in cases where it's left untreated, this chronic intermittent hypoxia and respiratory acidosis leads to cor pulmonale or pulmonary hypertension. Another key point here is that these individuals undergoing a surgical intervention such as adenotonsillectomy are higher risk for immediate post-op complications. And so based on the American Academy of Pediatrics recommendations, individuals with Down syndrome undergoing adenotonsillectomy are a vulnerable group of individuals for complications, respiratory and non-respiratory, and should therefore be electively admitted for observation. Now, moving into the tracheal bronchus. So this is otherwise known as bronchus suis. So this is the right upper lobe bronchus, which originates either at the level or above the carina rather than at the right main stem bronchus. And so it's shown in higher rates of Down syndrome in patients that undergo, for instance, bronchoscopy. So it could be a clinical manifestation such as right upper lobe pneumonia or atelectasis, but in most cases, it's technically a finding during their airway assessment with no clinical significance. We know that lower respiratory tract complications account for 80% of admissions of individuals with Down syndrome and 78% of all ICU admissions. And pneumonia is the single most common respiratory disorder, accounting for approximately 20% of all hospitalizations and 43% of admissions to the ICU for these children. And so respiratory illnesses in children with Down syndrome overall tend to be more severe, even leading to death when compared to children without Down syndrome. And they're more likely to lead to a longer length of stay, as well as to have a higher cost of care, about 2 to 3 times more compared to individuals without Down syndrome admitted with respiratory illnesses. The reasons behind are, again, multifactorial. So it could be due to decreased pulmonary reserve, and we're going to discuss this later. It could be due to chronic aspiration from above and below dysphagia and reflux. It could be obviously due to their underlying congenital cardiac defects, leading, for instance, to a large left to right shunt and pulmonary overflow, due to poor immunological function, which we'll be discussing later, as well as due to the fact that these individuals are undergoing any surgical intervention. So individuals with Down syndrome undergoing any surgical intervention are 2 to 3 times more likely to develop a lower respiratory tract infection compared to individuals undergoing surgery who do not have Down syndrome. So diffuse parenchymal lung disease is also seen in children with Down syndrome, as it can manifest itself as chronic radiographic changes associated with cough, wheezing, shortness of breath, crackles, or hypoxemia. It can even be an incidental finding in individuals undergoing imaging for other reasons, such as, for instance, a CT angiogram. It can develop as a result of a primary process or a secondary process. In terms of primary processes, we have pulmonary hypoplasia, which we'll be discussing in a moment. More rare causes such as pulmonary lymphangiectasia or lymphoid interstitial pneumonitis and other interstitial lung disease. Secondary would be things that actually we can acknowledge and address, as these secondary reasons leading to diffuse parenchymal lung disease can be either a combination of things or it can be contributing factors. And in this group, we have obviously bronchopulmonary dysplasia, so chronic lung disease of prematurity. It could be infection or post-infection complications. It could be cardiac and pulmonary vascular disease. It could be chronic aspiration. So, for instance, if we have an individual with Down syndrome who was born prematurely and has an atrioventricular canal that needs to be repaired, is found to fluidly aspirate from above and is placed on NG tube feeds, we need to correct the cardiac defect, and then we need to make sure that this patient is kept NPO and undergoes a G-tube placement, assess for gastroesophageal reflux and motility issues, and either do post-pyloric feeds or move on to a nascent fundoplication. And so this would help improve, all in all, the respiratory status. With regards to the pulmonary hypoplasia, we know that the Children's Interstitial Lung Disease Consortium has now a new classification of pediatric diffuse lung disease, which is termed growth abnormalities. And actually, this reflects deficiency in alveolarization. And this includes actually children with Down syndrome. So what we know is that children with Down syndrome are born actually with a decreased number of alveoli, reaching anywhere from 58 to 83% predicted. And this is independent of the presence of any underlying congenital heart defect. And not only do they have a decreased number of alveoli, but they do have enlarged alveoli and widened alveolar ducts. So there is a simplification of the alveoli, and this leads to a smaller alveolar surface area and therefore to a smaller surface area available for gas exchange. These individuals also have a retention of a fetal structure, what we call a double capillary network in the alveolar septa, which actually impedes and makes the blood alveolar barrier thicker. And you can see in these individuals that there is as a recruitment of their intrapulmonary and bronchopulmonary anastomosis as a means of compensation. Now, as a result of this pulmonary hypoplasia and deficiency in alveolarization and growth abnormalities, you may encounter subpleural cysts. And these subpleural cysts are seen about 20 to 36% of individuals with Down syndrome. And they're most commonly found in those individuals who have underlying congenital cardiac defects. Now, these are poorly detected on chest X-rays, but they're clearly seen on high-resolution chest CTs. They're usually numerous. Their diameter ranges between 1 to 4 millimeters, and they are in the periphery, but they oftentimes actually are placed along lung fissures and bronchovascular bundles. And these may communicate with more proximal air spaces, but they're clearly distinguishable from other pulmonary cystic malformations. And so all in all, they may be asymptomatic, much like the bronchus mentioned earlier, but at times they actually may cause issues such as pneumothoraces in individuals, particularly the ones who undergo surgical procedures and those who are on mechanical ventilation. So overall, moving on to cardiopulmonary interactions. So the pulmonary vasculature of children with Down syndrome demonstrates vulnerability that may clinically manifest, as we mentioned earlier, pulmonary hypertension, as pulmonary edema, which we'll be discussing, and as pulmonary hemorrhage, which we'll be discussing in a moment. So pulmonary edema develops more as a result of fragility of the pulmonary capillary network. And it's also reported as postoperatively in individuals with obstructive sleep apnea. So these individuals who undergo a surgical intervention, they may get intubated, and so you may have an acute relief of their upper airway obstruction. These individuals are predisposed in developing this postoperative pulmonary edema. And so the surgical and anesthesia teams need to be ready to address this complication. But another way of looking into how obstructive sleep apnea contributes to the development of pulmonary edema is as the one mentioned earlier, where chronic intermittent hypoxemia and and metabolic acidosis overall lead to the development of pulmonary hypertension, so cor-pulmonale, due to untreated obstructive sleep apnea.
5 minutes more.
So with regards to the pulmonary arterial hypertension, this is very important to notice that it occurs in individuals who have significant shunts from right to left, and also to individuals with recurrent hypoxic events. It also is due to the altered maturation of the capillary network with the retention of the double capillary network within the alveoli septa. It can also be due to genetic polymorphisms, which are encountered in these individuals with regards to regulating vascular resistance, such as the response to nitric oxide, which is a patent vasodilator. It could be in newborn period due to asphyxia, polycythemia, rarely hemangiothelioma, but one should remember that irrespective of the underlying cardiac defect in these individuals, there is a higher risk of pulmonary arterial hypertension, which in 40% of cases, the cause is unknown. With regards to diffuse alveolar hemorrhage, this is all in all encountered more frequently in children with Down syndrome compared to typically developing children. Again, a whole slew of etiologies leading to this. It could be due to pulmonary arterial hypertension. It could be due to congenital cardiopulmonary anomalies, such as individuals with left to right shunt. And so increased pulmonary venous pressure, for instance, due to mitral valve dysfunction or pulmonary vein obstruction. It could be due to infection and aspiration from above and below. It could be due to autoimmune diseases and immune dysregulation, such as capillaritis. And this is a clinical presentation of patients. Could be variable. It could be anywhere from an acute event such as hemoptysis or respiratory failure requiring ICU level care. It could be a more subacute chronic iron deficiency anemia, or it could be due to chronic dyspnea. It could also be a finding on imaging or an incidental even finding on flexible bronchoscopy done for other reasons, such as noisy breathing or recurrent pneumonias and chronic cough, where you see iron-laden macrophages. Just a quick reminder that not all children with Down syndrome who have wheezing have asthma. Actually, 2 large cohort studies of children in Australia looking into their inpatient admissions and outpatient clinic visits showed that children with Down syndrome actually have a lower incidence of asthma compared to what one would expect. And so while they have a higher rate of wheezing episodes due to viral illnesses, they have lower rates of atopy. One should also remember that we need to consider alternative diagnosis in children with Down syndrome who have wheezing and not attribute this directly to asthma, and such as tracheal bronchomalacia, which we mentioned earlier as the most common anomaly of the lower airway in these children, but also to other things such as chronic aspiration. It could be due to also cardiac asthma in these patients presenting in right heart failure. And
2 more minutes. Sorry, Dr. Sofia, 2 more minutes.
Sure. The most important also thing I'd like to mention here with regards to the GI respiratory tract is, again, that of chronic aspiration playing a role in the respiratory complications of these patients. Oftentimes, one does not acknowledge the presence of silent aspiration. And so these children may have symptoms such as chronic cough or recurrent pneumonias. They may even develop ARDS and end up in the ICU, or oftentimes they may be asymptomatic with regards to choking or coughing with the feedings. So there should not be only an SLP bedside done in these children. All these children should undergo a modified barium swallow study and video fluoroscopy in order to further assess their risk of aspiration. Just a quick reminder about the immune dysregulation, that it could be due to the reduced thymus size compared to age-matched controls. It could be a humoral as well as a cell immunity with decreased in number of T cells and B cells counts, but also in their function with regards to mitogen stimulation. And the take-home points then would be that there is so many reasons for obstructive sleep apnea. the airway is narrow everywhere. We need to use a smaller tube size in these children to avoid acquired subglottic stenosis and further complications. We should have a very low threshold for full overnight polysomnogram. We have so many reasons for pulmonary hypertension that we try to address: chronic hypoxia, double capillary network, and so many reasons for recurrent infections with a low pulmonary reserve, immune system dysfunction, and aspiration. We should therefore have a low threshold for video fluoroscopy studies. And remember, in respiratory distress and anemia, one should look for capillaritis and pulmonary hemosiderosis, and that the respiratory symptoms are always asthma. So thank you so much for your attention. And depending on the time, we may take questions either now or later.
Thank you very much. No, we'll take the questions now. Thank you for finishing in time. One question. Anyone from the hall wants to ask something? So I'll take questions from the virtual attendees. They're asking, what do you mean by moist sound during auscultation and assessment?
Moist or noisy breathing. I think maybe they are referring to crackles on lung auscultation, which could be, as we know, a sign of many different disease entities, such as, for instance, a lower respiratory tract infection, or it could be due to pulmonary overflow in patients with large left to right shunts. Not sure if I'm answering the question properly.
Yeah, I think that would be the one. And what does he mean by, like, how do you assess this sound? Like when you see these, hear those sounds, how do you assess?
Okay, so then obviously we have to take the history clearly and the physical exam. We need to then make sure that we auscultate the lung and the heart and do a general assessment, look for other signs of edema. Obviously, we're going to handle children differently if we suspect that they have pulmonary hypertension and if they have a previous cardiac defect, depending on what that is. So I'll typically do a chest radiography if I don't have a recent one in the office. If there are such findings, then I'll refer the patients to my colleagues in pediatric cardiology. Depending on whether there is a wheezing and there is a history of atopy, we administer bronchodilators in clinic and see if some of these sounds are clearing up or not. If there is a high suspicion for a lower respiratory tract infection, we will have a low threshold to prescribe antibiotics. If there is central homophonous wheezing, this may be due to the larger airways dynamic collapse. So that would be tracheomalacia and bronchomalacia. So there's a whole.
Yeah, I know. I think it will be another talk.
For, yeah.